Welcome, Dr. Okun. Welcome. Really is a pleasure for me. Yes, having you here is really an honor talking with you. Such an expertise on DBS, and I think that everybody will enjoy this little information and this super information about focus ultrasound that you have a lot of experience. So this will be the audience will be doctors, but also allied health and a lot of patients as well. So we can talk a little bit in different ways for doctors and as well for patients. So please, Dr. Okun, I will not introduce you because I want that you introduce yourself. Such a big curriculum. So please, this is your.
Well, I'll just say, what an honor to be here this morning and in different time zones for those of you that are watching all over the world. My name is Michael Okun. I'm a neurologist by training, and I work at the University of Florida at an institute called the Norman Fixell Institute for Neurological Diseases, and we do a lot of work in neurodegenerative and movement disorders and dementias and ALS and TBI and other disorders. And I also serve as a medical director for the Parkinson Foundation and have done a fair bit of work in my laboratory. I'm into my third decade. My hair's getting a little gray here, Mariana. And we train fellows from all over the world. We graduated another group of fellows, 4 fellows last night, going off all over the world. And Dr. Moskovich was one of our fellows now many years ago, one of our
10 years ago. Maybe we cannot say this.
So it's a 10-year anniversary. So it's a pleasure to be here. Our laboratory does a lot of work on just how brain circuits talk. We're very interested in understanding how all the different symptoms that you see, what is the kind of the language, the brain's language, uncoding that, developing devices for things for Parkinson to Tourette and other things. And we've been involved with lesion therapies for the brain and brain stem and trying to understand these circuits and trying to impact as many lives as we can. So it's great to have a discussion with you this morning, and thank you for having me.
Thank you so much. I know that you are one of the leaders in this field, and we know that this field goes and develops so quickly that we need to be all the time updated in all of these in this team and this subject, and you are updated all the time. And actually I used to update by your posts and by your readings, by your lectures. And we as a doctors, and we work with DBS, which is a lot of technology, we know that this will keep going like this, and we need to be on top in everything that is coming on in technologies to offer our patients maybe the best thing at the time to recover these lives and quality of lives. So thank you so much. And this is the idea to talk today about focused ultrasound, which I think maybe is not a super new thing, but it's coming, is arriving in Brazil soonly. And I know that you have already in Fixell Institute in the new center.
So we have a focused ultrasound machine to break the blood-brain barrier as part of a clinical trial. But we have not been using the technology to make lesions in the brain at this time. No.
Okay, great. So let's start in then as the main topic today will be focused ultrasound comparing with deep brain stimulation. So please, for people that are here doesn't familiar with focused ultrasound, can you explain what it is, focused ultrasound?
Yeah, so from a very just sort of basic nuts and bolts perspective, when we think about focused ultrasound, now think about this idea that you've got all these different circuits talking to each other in the brain, right? And so they're all having this conversation, and you can disrupt that conversation either by pushing in some electricity, or you can make a hole, in one of the nodes. So there's a whole bunch of different nodes, that are all communicating with each other. And so in very basic terms, what a focused ultrasound does is it is designed to make a hole, in the brain. And that changes the conversation pattern. And it sounds like, oh my gosh, that's horrible. It's not. It's actually a good thing. We've been making holes for a long time. When we make a hole in an area, of the brain called the thalamus, we call it a thalamotomy, meaning we make a hole. We make it in the pallidum, the GPI, globus pallidus, which is another just region. It's like, it would be like an island, on a map, it's an island in the brain. We make a hole, we call that a pallidotomy. and so forth. And so we can do this. And this technology has actually been around since the 1950s. There's a paper from 1958 that Jeff Elias, who does a lot of this work at the University of Virginia, kindly shared with me, showing, it in a neurosurgical journal there. And you actually, what you do is from the outside of the brain, you're going to push these, kind of sound waves into the brain, and you're going to use that in order to make a lesion. And so you're going to sonicate, they call it sonicate, to kind of ablate, to take care of that area of the brain. And here's the advantage, Mariana. The advantage is this, okay? If you can come from outside the brain, okay, then you don't have to make a hole, then you don't get infections, then you don't have to have a wire, then you don't have to program it, okay? Now that could be a disadvantage too, that you can't program it and adjust it. So it's more of a one and done if you can get the lesion or the hole in the brain in the right spot, and you can do it from outside the brain. And these sonications, when you give sonications, if you do them at lower levels, you can do what's called a test lesion, where you can kind of get a sense, is it going to cause a side effect or not? And so that's the basic technology. They have to put kind of a helmet on. You got to lay kind of in an MRI. And it actually takes a few hours. It's not a simple thing to do, but it is sort of a several hour procedure that when it's said and done, they will change the way that the different circuits in the brain are talking to each other by placing a hole, okay, or a lesion into one of those islands.
Wow, that's great. Yeah, maybe this is the best, better thing to do as you guys doing before, but open the skull and doing the lesion epididotomy or thalamotomy without having any scar or any bleeding or anything like that. So this is a huge advance, but I believe that this is not for everybody. So how can we indicate patients to do that? Do you think that this will make this will go towards deep brain stimulation, or do you think that this is a different kind of technology and some patients will be benefit for one and the other patients will be benefiting for the other one?
Yeah, so the way I like to think of it is none of us should be for or against any technology, right? Everybody wants to pit like, oh, this is better or this is worse or whatever. It's kind of like when people have different personalities or you learn something different about people. You have to meet the people where they are. So if we meet each technology where it is, then we can understand what it can offer and where it can have its advantages and or disadvantages for an individual person. So let's take focused ultrasound just for a second and just think about a few things. One, if a few percent of people, 5, 10%, it varies in different populations, but a few percent of people, their head's going to be too thick. This is funny. I hope my wife is watching this right now so she can hear me say this. But a few of us are going to have skulls that are going to be too thick for the sonication to go through. Okay, so if you can't shoot the sound wave effectively through it and aim it, then obviously focused ultrasound can't be an option for you. Now there are also folks who can't have an operation for another reason, right? You don't want to open up the brain maybe because they're on blood thinners, maybe because of their age. And I always like to say people are seasoned. They're not old, they're seasoned. Right? So it might be that they have some aspect when you've done screening on them. Maybe they have some memory. Maybe you're worried about some other feature. And so this might be, sort of a better way to approach this in a safer, type of setting. Now, one of the things we've learned, and those of us that have been around long enough, my hair is gray, so I've been around long enough to do lesions. In fact, we did a lesion here at the University of Florida, old-fashioned lesion here on Wednesday. And we did a thalamotomy for somebody. And the difference is when we do it the old-fashioned way, we make a hole, a little dime-sized hole. We record out of the brain with something called a microelectrode. So we try to find the spot and we develop a 3-dimensional map of it. And we go specifically to that area and we give little test stimulations before we make the lesion. And we're super careful that we're going to get the lesion in the right spot. All this has to be done with focused ultrasound from outside the brain. Okay. You can't do the mapping. You can't have the physiology. So your imaging better be really good and your targeting better be really good. And you can do some test sonications, but the test sonications are not quite as good as being in the actual brain and seeing it. And once that lesion is there, you're stuck with it. Now, the other thing to remember, Mariana, is that if we look historically, and I love history. So anybody that knows follow me on, any social media platforms, I love history, love to do history with my daughter and everything. The history of DBS, when Professor Benabid in Grenoble, and along with Professor Pollock, the neurologist, when they brought this procedure forward, a lot of the enticement, a lot of the, let's do this procedure, was because when you put two lesions in the same place in the brain, like in the thalamus, which is one area of the brain, or the pallidum, the pallidotomy in two areas of the brain, when you do it on both sides, people get speech problems, cognitive problems, and they can get what's called these pseudobulbar effects, and sometimes facial dystonias and things. And so there's been a real kind of, whoa, should we do this again? And if you make those lesions too big, if you're in the wrong spot, you may end up with these side effects. So that's something we've learned from history, and that's a reason why we do DBS today, because Benabid had lesions on one side, and he thought, what if I could stimulate the other side? What if I could leave it in? Like, what if I could leave the electrode in and be stimulating on the other side? What if I could do that? That would be awesome, right? And so if I was able to do that, then I would avoid some of these side effects. And so as we move along with focused ultrasound, it's mostly done on one side of the brain, although people are talking about, could it be done on two sides of the brain? And could we reduce, some of the side effects, infections, lead breaks, things like that? And can we as accurately get that lesion, at least that first lesion, in the brain? And then later on, maybe we could talk about whether or not there's a way to approach this to be safe with a second lesion. And so those are some of the things that we think about. And we still do a full workup, for folks. This doesn't mean you get off the hook, Mariana. So you still got to check their cognition. How do they think? Yeah. Be great to have a psychiatrist, be great to have a rehab team. And then a lot of people will have issues with walking, talking, and thinking after these operations. It puts you at risk for those things. So having some screening and a good team in place, kind of before you go, no matter what you choose for an individual, is super important.
Perfect. Yeah. So we still need to do all the fast track and all the multidisciplinary team previous indication of these patients. So this is great. They're asking if have translations. Unfortunately, no. Infelizmente não temos, que não é. Well, I think that we doesn't have maybe in the future with the intelligence, artificial intelligence, we can have some translation and Instagram, but not for now. So what is the advantages and disadvantages about focused ultrasound and DBS, comparing one to the other?
Sure. Okay. So if you're going to do a traditional DBS operation, okay, an advantage of that is you're going to be able to potentially use some physiology if you'd like, and three-dimensionally understand where this small target is. And remember the size of the GPI, for example, this is about 450 cubic millimeters. That's like the size of maybe 3 squished peas, and you'll want about a third of that. Now think about that, okay? Then you think about the subthalamic nucleus. The size of that is, about 150 or so cc's, okay, 150 cubic millimeters, okay? These are tiny targets, size of a squish pea. Then you want a third of it, because roughly a third, we know it's not exact, and these are kind of very rough estimations, but a third of these tiny areas in the brain carry motor features, like movement, and a third of them carry behavioral features, okay, and a third of them carry thinking features, okay? Behavioral we call limbic, thinking we call associative. And so the advantage to DBS is you can map it out, you can try to stay in the right area, try to keep the current from moving to the wrong area, and then you've got some leeway from programming the device, and then you can also program the device over time. So if symptoms change, you'll be able to do that. And then also, if in some circumstances, and we don't think everybody's going to end up with this new adaptive or closed loop DBS, but in some circumstances, the signals coming off in real time might be also useful for programming. So there's some ability to program. You can take the lead out, but remember, it's not completely reversible, meaning there's still some damage that goes in. We're surprised about how much damage it doesn't happen, how much we get away with, but there's still some damage going into the brain. It's still in operation. And then you've got potential for infections, okay? And you got to have battery changes potentially, depending on if you have a rechargeable, and wire breaks and hardware. Okay, so that's DBS. Okay, in a nutshell. Okay, so with focused ultrasound, as long as your head's not too thick and you can sonicate through, you can safely do one side of the brain. If you end up with a side effect, you might be stuck with it. You can try to test sonicate. You might be stuck with it. And so it's important shorten the experience of the surgeon, to do it in the different targets, so you can stay away from those areas, because you're not going to get to map like you do in DBS. And then once you have the lesion, there's no wires, there's no infections, you're kind of, all done. Now, important, and something that somebody asked me recently, I believe on Twitter or one of the social media channels for the Parkinson Foundation, and also has been asking Rachel Dolhun about these sorts of issues with the Michael J. Fox Foundation, who's also just awesome and has an awesome blog as well. So is about this idea of, could you have a DBS and a focused ultrasound together? And right now, if you have a DBS in place, okay, you can't do focused ultrasound on top. Okay, so
can we do it on the other side, like one DBS on one side? Doesn't make sense, but maybe.
Yeah, so it's hard. It's harder, and it's not kind of recommended at this time. It might be possible, but it's really not labeled to do that. And so however, if you have a lesion, you can add a DBS on, and we see people that miss with focused ultrasound or other lesion therapies. There's still a target, or we can go to a different target and add DBS. So that's something else to think about. And then again, you're safer with two sides with DBS or with a lesion plus DBS than you are putting two lesions in place. One thing I do want to mention to you, Mariana, is something that we're watching, okay, with focused ultrasound. Now, I will age myself here, and I'm going to tell you something, about the history of pallidotomies. When we would do these, back when I was at Emory, and now I'm at the University of Florida for the last 21 years, but back when I was at Emory with Jerry Vitek and Malin DeLong, we studied a lot, and those guys have a whole bunch of great publications. They are the masters of pallidotomy. You want to read the history of pallidotomy, read Vitek, okay, read DeLong, okay, and read Lexell, and some of these, the great folks that have been in this field that have pioneered, Marwan Haris. If you look, okay, at those series, what you will see is that lots of people got in the pallidotomy. Okay, so remember, when a new procedure, starts to get hot, there's a technology innovation curve. And the first thing that happens is there's a peak of inflated expectations. Everybody wants to do the new procedure, right? Woohoo! There's something great, right? Let's go, let's do it. And there's that peak. And then after that, there's a trough of disillusionment when people figure out it's not a cure and it doesn't do what you think it's going to do, okay? Early on in pallidotomies, okay, what we learned was lots of people started doing them and they made the lesions too small. Too small in the cubic millimeters. So people would come off and they would get benefit. But by 6 months, and particularly by 12 months, those small lesions, the benefit would disappear. We are worried about this with focused ultrasound. And we're going to have to watch this. The long-term data is there a peak of inflated expectations. Some of the focused ultrasound lesions disappear. And it reminds me of the disappearing lesions that we saw where people said, oh, look at the op node, everything. And we can't find the pallidotomy. It was too small. And then it disappeared like over time. We couldn't even pick it up in imaging. Our imaging is better now, 20 years later, so we'll have to watch that, okay? Making those lesions big enough, and then as people try to make lesions on the second side of the brain, they're even more timid about making it because they don't want to give people a side effect. And so it might be limiting, sort of from that. And so to remind people who are listening, when a therapy comes out and it's new, we want to actually see it out there, see what it does, see what the side effects are. We want to see some of that long term. But right now, focused ultrasound on that curve, the technology innovation, peak of inflated expectations. And some people that think it's going to do something that it can't, because it's just like a pallidotomy or a thalamotomy, lesions may be a little bit smaller and put in from the outside, are going to go to that trough of disillusionment. And eventually, as we learn where it fits into the armamentarium, it's going to ease its way back up here, kind of a plateau of productivity. And so that's kind of the way that I think about this.
Perfect. Yeah, I think that we have a lot of positivity and everybody's waiting, doctors and also patients always waiting for a novelty or something that maybe will change the real disease. But then we need to be more present and more realistic about understanding more about these new technologies and how it works and who will be the patient, exactly the patient that will benefit for it.
Absolutely.
So excellent talk. So what is the difference between talking about lesion, about ultrasound lesion? It's something similar with gamma knife?
Yeah, so a great question. Okay, so let's back up and talk about gamma knife. Okay, so if you think about, again, the history of this whole field.
Why not using gamma knife? This we're already using a lot, so why changing, right?
Yeah, and so actually, back early on in the first lesion, therapies, Irving Cooper and before Irving Cooper, people would actually do something. This is going to blow your mind, Mariana, and people that are listening. We would inject alcohol, okay, into the brain. And that's how we would kill off the brain tissue, okay? Not kill it off, but yeah, sort of. Like, so we're trying to kind of get rid of that piece of tissue and make a hole. So you could inject alcohol, right? That's a way to do it. You can put a lesion probe in. So on Wednesday, when we did a DBS here, we made a hole in the brain. We put an old-fashioned lesion probe in. We heat it up. It has a temperature monitor on it. And we make a lesion specifically in the spot we want. Then we make another lesion, and we can actually shape a lesion with a lesion probe. You can't do that with focused ultrasound as much as you can control with an old-fashioned lesion probe, okay? So then you think about, is there another way to lesion? And actually, before the focused ultrasound for movement disorders and Parkinson and other types of diseases. And by the way, it's not just used in the brain; it can be used all over the body. Right? You can use this technology to make a hole wherever you want. Okay. People shot radiation into the brain. Okay, and you can still do that. And there are these machines called gamma knife or radiosurgery LANEC system. So there's another type of radiosurgery. Is actually the LANEC system was actually pioneered here by Frank Bova and Bill Friedman. And many of the original innovations people use, like CT MRI fusion, were actually developed here at UF for radiosurgery, and now they're used in DBS. Totally other topic. But here, if we come back and we think about this, okay, how, Mariana, can we make a lesion? We could do it with focused ultrasound. We could heat a probe up. We could shoot alcohol in. But how about if we shoot an X-ray from outside the brain, like we were treating a brain tumor, but we treat that spot? Much of this literature is in what's called gamma knife. Okay, so you can do this with gamma knife. And we know from gamma knife that if you get the lesion in the right spot, you can also get, a positive response. Okay, and there's a group, I think, at Montpellier. I'm not sure if that's the correct place, but there's a really nice group that does these in France that has done some great work and some great publications, and other groups. It's a little tricky to do. And the issue with using radiation is there are delayed benefits, because you shoot the radiation and it doesn't kill the tissue off right away, right? The tissue is going to have to delay. It be delayed benefit. So you're not going to get off the table and say, if you're looking at trend, it's not going to go away right away. And then slowly it's going to go away, but also delayed side effects. And then if you use too much radiation or it spreads, you can get radiation necrosis. Okay, so there's a case of that in 2001 in a journal called the Archives of Neurology that turned out to become JAMA Neurology is the journal that is in now. So there's a series of referred DBS complications, that sort of, made the field pause a bit and say, okay, how could we do this more safely? And I think people are using lower amounts of radiation into those regions, looking at delayed benefit side effect, and they're worried about radiation necrosis. And so they've gotten a little bit better at it, okay, and maybe a lot better in some cases. And so that is an option, and there is risk with that option. Most people have turned now to the ultrasound option that comes to outside the brain if you're going to try to do it without mapping and coming from outside the brain, thinking this may be a bit safer. But just so you know, there are groups that are still doing focused or doing gamma knife as well as focused ultrasound.
Okay, yeah. So we always need to be aware about side effects in all therapies, and seems that gamma knife maybe in some cases we need to be more careful. So talking about this, what would be the indications about focused ultrasound? So we know now that mostly for tremor, essential tremor is a good indication. Correct me if I'm wrong, okay? Here in Germany, there is a lot of focused ultrasound for tremor patients, and they always give the patient the options. Oh, look, we have DBS and we have a focused ultrasound, this and that, and today have like a shift to focus ultrasound in essential tremor specifically here, not in all centers, but like the center that I'm going, and which is fair enough for the patient choose which therapy they wanted. So we put good and benefits and side effects, and they choose. But I see now they have a lot of studies coming on with Parkinson's patients. And can you discuss a little bit about these indications, disease indications, and also if you have something in literature about indications for Parkinsonism, So for other types of Parkinson's, PSP, as somebody asked here, or even though for psychiatry disease like depression, Tourette, obsessive compulsive disorder, as we know that it's coming more and more in DBS technology. So we are having more indications, we are treating more patients. The psychiatry diseases are blowing about indications in DBS. So do you think that this will be, but of course we started with movement disorders, Parkinson's, essential tremor. Do you think that in the future, maybe with focused ultrasound, we are going to in the same path?
Yeah. So, it's a great question. Okay. And, a lot there to unfold. And I would say, first of all, I've sat on a committee, with the World Health Organization where we talk about developing therapies for neurologic diseases like Parkinson's disease and in low income and in countries that may have less of economic infrastructures and things. It is clearly far and away going to be more cost effective to put a lesion in the brain and not have a device, and also for management. And so there are advantages, in not just in people that, might be high risk for DBS and other, things. There are advantages to how you can roll things out to the public health system. So saying that, and then if you look at the dailies or dailies that you look for daily, lost amount of work that's measured by the World Health Organization and others, you see that these neuropsychiatric diseases are way higher than Parkinson's disease and cancers, and they cause a lot of issues for people, challenges for people in their lives. And so absolutely right when we're thinking about where will this land. But I come back to this idea that we're at the peak of inflated expectations. This is sort of, this is new, this is shiny. Everybody's thinking it's going to cure everything. We're going to use everything. It's going to take all of these groups to begin to publish their experiences, to be real. And with these lesion therapies, we need follow-ups out to 1, 2, 3 years. We need to look at these disappearing lesions. We need to understand, who's going to be best so we can serve the persons with disease the best that we can. Now, I will point out, as we go through a number of diseases with obsessive compulsive disorder, that's like Howard Hughes, and it can be symmetry, but he had germophobias and things like that, afraid to get that. There has been a series of gamma knife done by Brown, and actually in Brazil, a group there. And there is an argument to be made in some of these types of disorders that we could get it to more people and we may be able to do it safely. So let's watch that. Let's watch what happens in depression. People have actually been making lesions in depression for a long time. Well, how will that do versus DBS if we understood the circuitry? Could this be a cheaper, better way to do it? So let's keep an open mind to that, and remember that focused ultrasound is just a technique to get to an ends to a mean, right? It's just a method, right, to get there. If we understand the biology and the circuitry, it's great. If folks will look in the literature, I follow this a lot on Twitter and Instagram and everything, all the new papers that are coming out, I love to read. And I'm an avid reader, so I'm always trying to keep up with the field, and particularly in my role with the Parkinson Foundation. As we see this, we've seen first it go to thalamus for essential tremor. And that seems to be the safest, perhaps because the thalamus is a pretty big structure. Okay. And if you're not using radiation, if you're using sonication, the side effect is going to be you get it into the wrong area. So it could be walking, it could be talking, it could be sensory, feelings, and some are going to be transient. And people have limited most of their publications to one side of the brain. And everybody is very timid, although they're going to try it on two sides of the brain, very timid. We need to see if you do it, how big those lesions are, and follow them out for 1 to 2 years. Essential tremor in the thalamus seems to be, like the sweetest spot, for this right now on one side of the brain. Right now, from where the literature is, I don't want to, make anybody mad by saying that, but that's where the literature is. And then there are people doing it for the subthalamic nucleus, which is tiny. So you see a really nice series of papers by Fernandez Martin and by Jose Obeso in Spain, and Andres Lozano and Jeff Elias. And Jeff Elias has been, on these early papers and done some great work at University of Virginia, several New England Journal of Medicine papers. So you see in Parkinson's disease, you can do it for the tremor. You got to make that lesion really big and get it more anterior, into what's called the ventralis oralis, anterior and posterior and thalamus, to get into the palatal receiving areas to get more symptoms for Parkinson's. So it's mostly tremor. And so it may not be, as useful in Parkinson in the thalamic target, but now you have people like Obeso saying, what if you went unilateral one side of the brain into subthalamic nucleus? Could we learn how to do that? And could that reduce the amount of side effects and morbidity in the wires and everything? And maybe one day get in bilateral. Series of great papers in Lancet Neurology and in other journals on this issue. And then most recently in the New England Journal of Medicine, Jeff Elias and a number of other folks, Vibor Krishna, who was at Ohio State, who's now at North Carolina Chapel Hill, another great neurosurgeon, has published on their experience in the New England Journal of putting a palatal lesion in the brain and seeing how they do with that. If you compare that historically to the data of Parkinson disease and how they did it, and they have to stay away from an area called the optic pathway, which is one of the big side effects when you put a lesion in the pallidum, you got to make it big enough. The data is not quite as good as I think a number of the experts would like to see, but there it is. It is in the New England Journal, and they are showing that it is possible to put these lesions in this place. And so we're going to see more of it. And so what would I say? Let's see what it does. Let's watch it long term. Let's see if those lesions disappear, and let's see if we can get past that peak of inflated expectations and figure out where where we're going to see the plateau of productivity.
Oh, great. So we need more studies, and we still need to be patient. People, they want to right now. And unfortunately,
nothing wrong with that, Mariana. Like people are, people are suffering. And I always think about clinical trials, and I remind folks that when we think about clinical trials, we should always be thinking about, there's a famous picture, and there's several famous pictures of a man standing, it could be a man or a woman standing on a globe looking at their watch. And they're saying, oh my gosh, I have this disease, hurry up, let's get the trial going, hurry up. So we should respect, folks that want to get this information. And all I can say is the best thing that we've learned, over the past several decades is just publish your information, whether it's positive or negative. Don't publish your positive results. Same in DBS. And people say, Dr. Foote, who I've worked with for years, who I think is just, an absolute expert at DBS.
Send a hug to him, please.
Yeah, I will say hello to him. I think he's awesome. And he often says, Michael, you make me famous by publishing my side effects and my complications.
The troubleshooting.
This is so important, right?
It is.
If there's one thing that I could just say to people, it's like, no, I don't want to criticize everybody. I want to have an open mind. Let's see what all these things are. But let's get as much information out as we can so that when we are sitting doing shared decision making with real people with real diseases, we can offer them as much information as possible. So we don't cherry code it. We can understand, and we can understand who are the best folks. And you asked that question earlier. You said, how do I know if I'm the best folks? Well, a multidisciplinary evaluation, same as you would do for Parkinson's disease now for DBS. Don't skip any steps. Don't just say, oh, you have more, let's go. That's going to be super important. And looking at each individual person. Now, the other thing that I will tell you, here's a couple of little pearls. Okay, so people that follow me know I like pearls.
Take notes. Just one small commentary in Portuguese, because everybody's asking, please, translation. Yeah. So I was talking in Portuguese. Pessoal, aqui no Instagram não tem como a gente colocar tradução. Talvez se eu fizer uma edição, até que se alguém quiser fazer isso por mim, agradeço. E no YouTube é mais fácil, vocês só ligam depois ali as legendas, possivelmente vão ser em inglês, mas pelo menos vocês podem ler, e eu vou tentar depois, em algum momento, fazer uma edição e colocar as legendas em português. Então, neste momento não dá, porque estamos falando em inglês. My Dr. Okun speak English, not Portuguese, Dr. Okun. Next time in Portuguese, huh?
Yeah, I'm working on my Portuguese. A number of Brazilian fellows. In fact, we have 3 or 4 now in the lab. So
good. Yeah, I know. So we have a huge fans in Brazil. So you need to do like a rock star bands, like say 3 words or 3 sentences. Then everybody, are happy.
I'm afraid people probably don't want to see me dance or sing, but having said that, let me give you a few pearls.
Go.
Okay? Yeah. Okay. So the most common thing that you're seeing these days is people with tremor, okay, essential tremor or Parkinson's tremor, okay? Now, if you're going to approach somebody with focused ultrasound or thalamotomy or deep brain stimulation, here's a pearl for you, okay? Look at where their tremor is, okay? It's super important. Okay. Is it distal? Just, like if you have their finger, do you see, I'm going to pretend like I have a tremor. Here's a functional movement disorder. Okay. And you want to see, is it there? And is it in the wrist? Okay. Is it in the elbow, or do they have it in the shoulder, right up here? If you regionalize, the higher you go, okay, the more proximal the problem, the less chance you're going to get a full response from any of these therapies, whether it's deep brain stimulation, whether it's focused ultrasound. And you're going to need more somatotopy, more areas of the body, because where the thalamus is, so if you look at the thalamus, it's like an onion skin. Okay, it's a huge structure. I mean, it's huge. Okay, and it's like an onion skin, and the shoulder and all those regions are really large. Okay, and so so your best bet is the more distal you are. Okay, and then when you're talking to people, when you're doing shared engagement, whether you're going to do DBS or lesion therapy, you need to let them know that that it's not a forever thing. The tremor is going to progress, but it's probably more ataxia. It's more clumsiness that's going to progress over time, even if your DBS or your focused ultrasound works. Okay, so this isn't like Parkinson tremor. Okay, if you suppress Parkinson tremor with a good lesion or a good DBS, a lot of times it stays suppressed for the life of the person in many of these cases. In essential tremor, not so fast. Okay, remember your regions. It's going to spread. As it spreads more proximal, it's harder to control. If you have a very proximal tremor and you go after it with a focused ultrasound or lesion, you got to make that lesion really big. Okay. And if you make the lesion really big, you're going to get into more side effects. Okay. Same with DBS. You might need more DBS leads to get it as it becomes more proximal. Okay. So super important to keep this in mind. And also remember, in shared decision making, it's so awesome that people see all these videos, from companies, from people, from Mariana Moscovich. They see all these videos online before and after focused ultrasound or whatever. This has been around a long time. Irving Cooper has a picture. I think it's on the cover of either Life or Time, one of those. They used to have these huge magazines back in the 50s and 60s showing when he did a pallidotomy or a thalamotomy, how they're holding the hand of the person. It's not a video, but he's holding the hand, showing how the hand goes silent, right? It's amazing. People buy into this because it's amazing, and they should. What they need to understand is if it's not a Parkinson tremor, if it's essential tremor or something else, it's going to get worse over time, no matter if you have DBS or you have a lesion therapy, and they need to understand that that's the natural history, and there'll be probably some clumsiness that comes along. And the more proximal it is when you start or as you go, the worse the potential long-term outcome. And so these are things to watch out for. Here's the other pearl. Have folks with tremor walk 1 foot in front of the other, okay? Like you're walking the line, like you're drunk, right? Tandem, right? And if you have tandem balance problems, get them into the physical therapist and be really careful how big your lesion is, and be really careful to warn them, particularly with bilateral therapy, but even with unilateral, you could make them worse. So you could have somebody that is walking with poor balance, and then you put a DBS in, or you put a focused ultrasound lesion in, and then all of a sudden they need a walker. You push them over the edge. You have to be really careful, okay? And you high five and you say, "Oh, we got the tremor, it's great." But what happens is that you made something else worse. Their speech, okay? Slurring of speech and walking have to be looked at on everybody, and the region of the tremor. Those are my 3 pearls for you today.
Great, that is awesome. Great pearls from all the experience that you have. And we still have these issues with DBS, maybe the most common side effects, speech and gait, and some people can really get worrisome about these. I have patients that are journalists or the profession is about talking, but they have Parkinson's and but they say, please, my voice needs to be the same and how can you make sure that the person will not have any side effect as voice? So the multidisciplinary team approach and take careful about all those pearls that you gave us is really amazing.
Yeah, and just be honest. So there's a term called Pollyanna where we all try to be over honest. People can, they can take honesty. They appreciate honesty, and you just tell them, look, not everybody with this looks like the video on here. It can be very effective. And these are the things that we watch out for. We don't want to make your thinking worse. We don't want to throw off your balance, and we don't want to, make speech slurry. But guess what? there's a good chance their gait is going to be, or their walking is not going to be as good after a DBS or a lesion operation. There's a good chance that they're going to slur their speech. There's a smaller chance they'll have a cognitive issue. Just discuss it with them. Document it in the chart, discuss it, just be honest. And that's why we need to publish more. We need to understand more. And then as we follow, folks, everybody do us a huge favor, publish your cases, share your cases, and follow your folks that are having lesion therapy. We have a lot of multi-year studies now in deep brain stimulation. We don't have multi-year studies yet for focused ultrasound. We need to see those lesions over time. We need to see how people are going to do. And my suspicion is that when the lesion, sustains and it's in a good spot, people are going to get similar effects to DBS or to traditional thalamotomies. It's just another way to make a lesion, but we need to understand that, and we need to understand the natural history of what happens to a lesion when we make it with different, modalities. Of course, we don't inject alcohol anymore; we drink it. So that's good.
Yeah.
But we do need to, be focused on, getting as much information out there. It's important so that the shared decision making between clinicians and teams and folks that are thinking about these things, that we're not for or against any of these, okay? And people like to say, oh, you're for DBS because you study DBS your career. Well, I did a lot of lesion therapy earlier in my career along with DBS. Remember, it was lesions first and then DBS. I'm not for or against anything. What I'm for is to get as much information as we can, so when we reach a shared decision-making point, we can help people to make the best possible decisions to impact their lives in the right direction.
I agree this totally. Even though with medication, we always need to tell the truth to the patients and say, look, this is the best medication, but you have this, and this, or you can choose between this one. And it's not only about therapies, but also about medications and about everything in life. We need to choose, and you maybe you have some side effects in the middle. So be honest. I always learn from University of Florida as well that you always need to talk with the patient a lot and be honest about what can happen as good or as bad, and then the patient will decide. So the expectation of the patient at the end and the result is much better because they know what to expect, and you be real with the patient, right?
Absolutely. And I think that's just spot on. And if I was going to just encapsulate this entire discussion, it would be our job as folks that are in the healthcare industry, and our teams, is to take care of these people, the patients, the persons with disease or the sun. We orbit around them. Let's get them as much information as we can. Let's keep them as safe as we can. Let's use everything that we have, our teams, our imaging, everything, to keep making things better, and then to help them to share decision making. In the end, it's their lives. It's not our lives, and we just help them to impact as much as we can.
Exactly. I think I think this is a great message, and we, as much information as we have, much information can pass on. This is the idea about this channel, about Instagram. Like after pandemic, everything changed, and I think that people are having more and more good information. So we need to always learn so we can pass good information to our patients and make good decisions. So I think that we are getting to the end. Thank you so much, Dr. Okun. Somebody tell me that has some echo, but I'm listening good. I don't know if you are having some echo when I'm talking, but it's okay. It was a great pleasure to talk with you these 40 minutes. I learned a lot. I probably know that other persons, doctors and patients learn it as well. So this will be saved here in my Instagram, my YouTube. And I hope we can do this more often and bring all your expertise here. I know that your time is tight and you are all around the world. But it's a real pleasure always to talk with you. Thank you so much.
It's my pleasure. And it's great to see you, Mariana. And good luck to everyone. And go help as many people as you can.
Ok, Dr. Okun, just to finalize, o professor Okun, ele é também professor no curso DBS Expert, e vamos estar trazendo mais informações para vocês. So, Dr. Okun, I hope to see you also in Copenhagen, and personally, maybe we can do a live personally. And okay, have a very good weekend. Say hi to our family, for everybody at UF. Thank you so much.
Thank you.
Bye-bye.